Good morning and good afternoon, everybody, and welcome to this fireside chat, a pragmatic view of health disparities and inequities among the Black community, disconnects and implications for clinical practice. And this is part of OHG's Black Health Now series, which is centered around healthcare, the healthcare experience of Black patients globally. So I'm Ruth Lynn Layla, and I'm Director of Scientific Services with HCG, and I'm here with my co-moderator, Jonathan, who will introduce himself.
Yeah, thanks, Ruth Lynn. Hi, everyone. Jonathan Wirt. I am Senior Vice President of Medical and Clinical Strategy at the Healthcare Consultancy Group.
Thanks, Jonathan. And of course, we're very privileged today to welcome our esteemed guests, Dr. Ashley Butler and Dr. Christina Davidson, and I'm going to ask them to introduce themselves also, and we'll start with you, Christina.
Hi, good morning, everyone. Thank you for joining us today. I'm Dr. Christina Davidson. I am a maternal fetal medicine physician at Baylor College of Medicine in Houston, Texas. And I am also the Chief Quality Officer for OB-GYN at one of our hospitals, and I'm our department's Vice Chair of Quality, Patient Safety, and Equity. And my interests and expertise are in complications of pregnancies and health equity.
Thank you. And Ashley?
Good morning, everyone. It's a pleasure to be joining you this morning and afternoon. I am Dr. Ashley Butler. I am a clinical pediatric psychologist here at Texas Children's Hospital and Baylor College of Medicine. In addition to providing patient care focused on behavioral health services for children and families, I spend quite a bit of time actually doing research focused on health disparities in children with chronic conditions, primarily mental health conditions and pediatric diabetes.
Thank you, and welcome again to you both. And we're really looking forward to our discussions with you and to hear what you have to say. So we know that a significant proportion of our Black communities report experience poor or inadequate healthcare because of their race. And when we look at the data, we understand that this is not just a figment of their imagination. For example, as we can see here, the rate of pregnancy-related deaths among Black women far outstrips that of other ethnic groups. Time and time again, Black women are dismissed by healthcare professionals when attempting to raise concerns about their health. And this can happen regardless of socioeconomic, professional, or even celebrity status. And sometimes this has life-threatening or even fatal consequences. So we see here just two examples of that, where Serena Williams, recognizing symptoms of a blood clot, was dismissed repeatedly by her nurse. And really, it was only because of her tenacity and persistence that she eventually underwent the scans that actually proved her suspicions to be true. Dr. Shaylin Irving, despite her professional status as a lieutenant commander in the US Public Health Services Commission Corps and a CDC epidemiologist, sadly died after her concerns were repeatedly ignored for 3 weeks after delivering her baby daughter.
All right, let's dive right in here after that. Thanks, Ruth Lynn. You know, Ashley, there are a lot of definitions, connotations, and denotations when you think of health disparities, inequities, and social determinants in the Black community. What most frequently comes to mind?
Thanks, Jonathan. As you noted, yes, there are a lot of definitions out there. When I really think about the topic, I think about reasons why there may be outcomes that Ruth Lynn just discussed. I think about health inequities, and really health inequities being factors that are unnecessary, that they are actually avoidable, that they're unjust things that we see. When we think about the Black community, we know that there are inequities across a number of healthcare metrics. We see that Black individuals, ranging from children to adults, so across the lifespan, we see that they're less likely to receive advanced technologies to treat a condition, We know that they're also less likely to undergo certain screening and diagnostic procedures that will really be necessary to identify the health problem they might be presenting with. We also see things like they're less likely to have, or they have less time that they're actually spending speaking with their doctor or their physician. So when I think about health inequities, those are some of the factors that I see as really being potentially avoidable and unnecessary and unjust. When we think about the social determinants of health, again, we think about factors oftentimes outside of the healthcare system that could contribute to those health disparities or poor outcomes in the Black community. We could think about things such as neighborhoods. We know that, for example, Black people are more likely to live in neighborhoods where there's more pollution, and that's something that could contribute to poor health outcomes. We also know that Black individuals are more likely to experience stressful experiences related to discrimination and racism. We also know that another interesting piece is that we also know that Black adults are more likely to be employed in a situation where they have less flexible or less predictable work schedules, which could contribute to their ability to receive medical care consistently, especially for things such as chronic conditions. And so it's those two social determinants of health inequities within the healthcare system that I see as major factors contributing to those disparate health outcomes. So things like higher rates of death in the Black community, having a shorter lifespan among Black individuals, or things such as having higher rates of chronic conditions.
Great. Thank you. Christina, can you lead us through some of your nuances that you see in the maternal fetal health and women's side of the coin, given kind of what Ashley was teeing up here in those categories?
Yeah, absolutely. I mean, to build upon what Ashley was talking about, I think as I've come to learn more about the health disparities and the health inequities, I think sometimes the terminology we use may be confusing to people, and some people use disparity and inequity interchangeably, and in actuality they aren't, as Ashley was just describing. So the disparities are really just those differences that we're describing, as Ruth Lynn described earlier, the differences in health outcomes between groups within a population. So it's really kind of the way we graph or the way we describe things. So for example, when it comes to maternal morbidity and mortality, Black women are 3 to 4 times more likely to die as a result of pregnancy complications as compared to white women. But again, this is independent and irregardless of education status and socioeconomic status and health insurance. And so the inequities are the root causes that are leading to these disparities. So the disparities is really just describing the outcomes in terms of differences, whereas the inequity is actually that barrier or that social construct or social determinant of health that, as Ashley mentioned, is avoidable, it's unfair, and it's unjust. And so these social determinants of health are really those factors that exist within the environment where we all live and we work and we grow and we raise our families, but they're really shaped by historical and social and political and economic forces. And so to a large degree, it's been the result of years of structural racism that have impacted how our ultimate maternal health and just health in general come out to be. And so even from a standpoint of morbidity, so as Ruth Lynn pointed out in those 2 women that she described, one actually went on to experience a pregnancy-related death, and the other one, Serena, experienced morbidity or complications around her pregnancy. So while she did not die, she experienced significant complications, and Black women are also at 2-fold greater risk for having complications related to pregnancy as compared to white women. And again, independent of any factors, including independent of social determinants of health. So while the social determinants are the structural barriers that are rooted in systemic racism and policies and procedures that drive these disparities, sometimes it's really just at the individual practitioner provider level. And there are different models that describe what the reasons are for why these disparities may exist in maternal mortality and morbidity, and even just various different health comes across all of the fields. And they can really exist at the provider level, at the patient level, and at the system level, with the system being like your healthcare system. But just even as an individual provider, if someone's coming to me and complaining of something and I'm dismissing their concerns as you're just confused from your pain medications, which is what Serena Williams was told, or, this is just a normal part of having a baby, you're just tired, just give it some time, which is what Shalon Irving was told, then if I dismiss those concerns, that can lead to significant consequences. And so unconscious bias or implicit bias is also a root cause for these inequities and disparities. And I think that's something that we're really trying to pay closer attention to and work on as we evaluate and really dig into these root causes. Because I think in our medical careers, we have been learning about these disparities for a long time, but I feel that we're really just now starting to dig into the actual root causes. And the social determinants of health are those causes that are considered to exist more upstream. And so, the time that I spend face-to-face with a patient is just a minor part. And even the care that I provide in the clinic or in the hospital setting is really just a minor part of the overall health and well-being of a person and their family. And I think it's important that we recognize that there are a lot of downstream factors that we need to impact in healthcare to really lead to improved outcomes. Because when they walk in our hospital doors, that's not the beginning of their journey. That's oftentimes like the middle or end of it.
Thank you. And that's really interesting point. And I wanted to ask both Christina and Ashley, we all know that there are sort of intrinsic and unconscious biases. Do you think that there are any prevailing myths about the Black community and about Black people that really sort of underpin these unconscious biases and that are contributing to the disparities and inequities that we observe?
Sure. I think one of the things I often see and think about is or stereotypes around sort of intelligence and being able to understand or really take in complex medical information. And so sometimes I think what that turns out to be is that Black individuals are less likely to be provided with information about particular treatment options or choices. I think that oftentimes you could see that in the Black community, there may be less likelihood to be aware of, especially like I mentioned earlier, some of the advanced technologies that may exist to treat a particular condition.
Thank you.
And I think also just another myth is just defining race, and that race is not a biologic construct. And so race is a social construct that really, it's not about the DNA. And so when you recognize, and I think that's something that we've all been guilty of kind of believing in, is that there is some biologic reason why Black people have poorer health outcome. And that is not the case. It's a social construct. And a quote that I've heard a lot that really resonates with me is that race is not a risk factor, racism is. And so it's someone's exposure to racism and discrimination. And I think that, and also, I think knowing the disparities in the literature can serve as some unconscious bias. We see that Black women are more likely to have a cesarean delivery as compared to a vaginal delivery. And so because we already know this to be the case from the published literature, it may lead to more biased care during labor. If I am taking care of a Black patient in labor, and I already know the statistic that Black women are more likely to have a C-section, I may be quicker to jump to a C-section or recommending a C-section if I see like the first sign of fetal distress versus trying to improve things and continue the labor. And we see that to be nationally recognized, where you take the same group of patients, a very low risk patient population, and you still see that Black women and Hispanic women are more likely to undergo cesarean delivery as compared to white women. And now the literature is starting to comment on, it used to be, if you even look at articles from 5 years ago, when we identify a health disparity, the conclusions and the discussion may go into, it may be because their pelvis is biologically different, or they have a different shaped pelvis. And now the discussions are, it may be the physician bias in terms of how they're approaching the labor management. So I think some of these myths are just embedded in how we've been trained in healthcare. And there's myths to pain tolerance, and there's literally nursing textbooks that teach that Black people have, they experience pain differently, and they may complain of pain when they like don't really have it, type of thing. And so pain is not getting addressed in the Black community for the same types of surgical procedures. And so there's a lot of different myths that really do have significant medical impacts.
Speaking of myths, but then biases, and also our training as healthcare providers, you two are also your mothers, your sisters, your daughters. You have another facet to your life beyond just being a maternal fetal medicine provider and a child psychologist. Can you share insights on the dichotomies between what you have seen or experienced as a provider, but also as a quote lay person, whether it's been through experiences with friends and families, or even some things you've experienced as a healthcare consumer, so to speak?
Ashley, do you want to start?
Sure. I would say, there's one particular incident that comes to mind. I recently was watching The Color of Care that was produced by Oprah, and it sort of went through a number of stories among Black parents, among family members who, one of the patterns that I saw was really this: folks who were experiencing COVID symptoms went to seek care and were either misdiagnosed that they did not have COVID, or they did not receive the proper testing for COVID. They were just, denied access to receive that test, or they were actually turned away from care. So even when they knew that the individual had COVID, they did not, receive the level of care that was needed to keep them alive. And through that, you could see the devastating outcomes in terms of those individuals died. And that really, when I was watching that, it really brought me back to an experience with my son when he was 5 months old. Actually, he was born with a congenital condition that normally is identified very early, probably before you even leave the hospital. But I think because his condition was quite mild, we ended up, it was not identified early on. But as a new mother, I knew that there were some symptoms that he was experiencing where I knew something was not quite right. And I really went to the pediatrician probably 5 or 6 times explaining what I was observing and, really wanting them to dig deeper to try to understand what might be happening with my son. And each time I was sort of turned away. Everything's fine. He's fine. And, I ended up, because the situation got pretty significant, that I ended up taking him to the emergency room. And then at that time, he immediately needed surgery. And I just really remember that the surgeon came out and said to me, "Oh, Mom, you did a really good thing. You did a good job bringing him here to the emergency room so that he could get this surgery that he needed in time." But really, yes, as a mom, before that, I did a really good job in trying to seek care very early, but didn't receive it. And so just in my case, the situation was not as devastating. My son is healthy and doing very well and about to go to kindergarten now, but you could see that there are situations where the outcome isn't quite as positive.
Thank you.
And I don't have as personal of a story to share. But I've heard of these exact types of situations from colleagues. And I think just even in terms of, when an OB-GYN gets pregnant, I feel like there's a subgroup of us that wants to deliver at the hospital where we work, and a subgroup of us that wants to deliver somewhere where nobody knows you, because they want more privacy of not delivering where they work. And I fall into that subgroup of, I delivered at the hospital where I trained. And so I was, treated like royalty. I'd, been there for years. They all knew me. They knew my husband. He had trained there as well. And so I had no delivery concerns whatsoever, and recall them all as being very wonderful experiences. Whereas I have a colleague who is also an OB-GYN, and she chose to deliver at a hospital where she doesn't work. And she had some really serious complications of high blood pressure after delivery. And she kept trying to tell people her blood pressure was high, like getting to the point even where she was having a hard time communicating because she was just so sick. And she kept trying to explain to people that she needed treatment. And she said they just kind of kept dismissing it. And finally, she said to the charge nurse, I am an OB-GYN, and at my hospital, I would be treating someone with blood pressures like this. And she said that nurse walked out of her room and she never saw her again. And so I have a tendency to kind of hide behind my scrubs whenever I take a family member, go anywhere with a family member for healthcare. I normally work in scrubs as an OB. I spend the majority of my days on labor and delivery units or inpatient units with pregnant women. I never know when I'm going to be in the midst of a stat C-section or a delivery. And so I'm usually in scrubs, and I pretty much go everywhere in scrubs. And so, like if I'm going somewhere after work, and I find that I get talked to very differently. And my mom has noticed that her doctors talk to her very differently if I'm at a doctor's appointment with her in scrubs versus I'm not there, or I'm there in regular clothes.
Thank you both for sharing those very personal stories. Ashley, very happy and glad to hear that your son is healthy. We want to move on now to thinking about, how do we begin to change things? What needs to happen? And I want to start by asking you both about the current state of education. What are your feelings about education around this topic, around disparities and inequities? Is it, do you feel that it is sufficient? What more needs to be done? So maybe Ashley, I can start with you on that topic.
Sure. I think one of the pieces that I see is, as we started this conversation, and Christina mentioned, the root causes of disparities. I think we've known for a long time that there are disparities in a number of outcomes in the Black community. And oftentimes I feel like education focuses on just describing what those differences are without contextualizing, historical reasons, as well as, current contextual factors, like the things like the conditions in which we live, work, and raise our families. What are those conditions that are contributing to the disparities? And then I think the other piece is that, I really see that there are very little solutions that are put forth as possible things that, we as providers, as healthcare, the whole healthcare industry and healthcare institution can really engage in to help really reduce what the disparities and the inequities are. I think, I think the main thing is that we really focus a lot on describing without solutions and without really understanding why the situation, looks to be what it looks to be.
Thank you. And Christina, would you like to add to that?
Yeah, I think to Ashley's point, there's a lot of education around describing that there is a problem. I think what we need to, and coming from a quality, patient safety, and health equity perspective, my job with any disparity in outcome or any adverse outcome is to try to identify root causes and to get at that root cause and fix it. And I think in some respects, when you're getting at root causes being, the impact of historical racial residential segregation. Well, you may say, well, neighborhoods aren't segregated anymore. You don't have to live in a certain place. But the thing is that they are, because they have been historically. And so while, yes, that person doesn't have to be there, that they could move, maybe that's where their family has grown up for generations. And those neighborhoods don't have the same resources because historically they were redlined and didn't have investment. And so there's food deserts. They don't have places to go get healthy food in nearby grocery stores. They may have to travel far to get to healthcare. And then for me as a specialist, I am maternal fetal medicine. You don't come to me for just your routine prenatal care. You come to me because there is a complication with the mom or the baby. And so there may be people who don't have access to maternal fetal medicines in their nearby area. So what are we doing? I think, for example, COVID really brought to light, I think everybody was becoming more aware of disparities with COVID, but it was interesting because as I was watching this all play out on the news and how the news was reporting these shocking disparities and outcomes, like in infection rates and hospitalization rates and in death rates amongst the Black community, it's all already been happening in healthcare. I think it took a global pandemic for everyone to realize that this is something that we've all been dealing with, and we need to really work to fix this. And so things like with COVID, how do you get people vaccines? It may be that you need to take it to the community. How do you provide prenatal care? How do you get people to access prenatal care early? Well, not having barriers to health insurance is one of those. And so I think it's important to really, as you're thinking through, okay, what am I trying to fix? You really dig deep of what is underlying, what is at the root cause of this. And that's why I do appreciate that at least the discussions and articles now are putting some ownership on the providers taking care of these patients and saying, we need to re-examine how we're actually responding to, what a patient is telling us, or how we're responding to what the fetal heart rate monitor is showing us. And make sure we're targeting education in a way that's not blaming patients and saying that, well, because they're non-compliant, they're not coming to their appointments. What are those barriers to compliance? And I think that's where the education really needs to focus on is, it's a little bit of a soapbox that I have when I'm talking with my residents is, instead of, my patients taught me what social determinants of health were long before I knew the terminology. And when you're a maternal fetal medicine provider who works in the Texas Medical Center that has probably the most expensive parking of anywhere in Texas, and you've got a patient population that needs to come to the hospital once or twice a week for 9 months, then you really start to learn about what barriers exist to getting to your appointments, getting to them on time, sitting in a clinic for 4 hours, waiting for all of your appointments to be finished and having other children that you need to be taking care of, and what those other obligations are in terms of childcare, in terms of picking someone up from school, in terms of now you're in a pandemic and all your kids are at home sharing their devices to be able to do virtual school. And so, how are you supposed to leave them there while you come to a doctor's appointment? So those are the things that we need, or your health insurance doesn't cover your home blood pressure monitor. Your health insurance doesn't cover the insulin medication that I need to give you. And so those are those barriers that we need to be educating about and to try and work to eliminate these disparities, because disparities won't be eliminated until those inequities are eliminated.
And I'd like to emphasize what Christina said about, this tendency to focus on individual factors or reasons at the patient level that the health outcomes, look the way that they do. I mean, I think part of when we provide education too is how we frame our communication, when we're giving education about these concerns. We know from psychology research actually that when you're talking about the topic of race and ethnicity, when you just start the conversation by talking about what those health differences are, there are higher rates of death, or there are higher rates of complications, that people, just the way, as individuals, the way we tend to think about race in a common way is to think about things at either the biological level or at the individual level. And so you oftentimes, in an education setting, you could lose people when your real message is around the social determinants of health, or around provider level factors that are contributing to the disparities, or even larger institutional policies and practices that are the reasons why. So, and what that psychology research shows us is that there's really a need to start the conversation by starting it with a common value that what we're all here to do is provide good health care to all, and for everybody to have the opportunity to be healthy, and then start to talk about what some of those inequities or social determinants are. before you even start to really emphasize what the major health disparities or the major differences in outcomes are. It helps open them up to new learning and to think about things in a different way than the common way of thinking about biological factors and individual factors.
Thank you. And you both answered this question in terms of educating the medical profession now. And before we just quickly move on to talking about your hopes for the future, I wondered if there's anything that you feel that at a more fundamental level, say that the medical schools in terms of that education can be doing to start to impact on the next generation of doctors to maybe prevent the health inequities and the biases, to address those biases that are driving the inequities and disparities?
Yeah, I think medical schools are already looking at their curriculum and looking at how they're teaching things and what they're teaching. And just to even use our medical school as an example, Baylor College of Medicine, it's a program that they started, I want to say back in 2016 or 2017. But, for anyone who doesn't know, Houston is the most diverse city in the nation. And diverse in terms of race and ethnicity and religion and culture. And really, I can speak a different language with a patient, be an interpreter in every clinic room that I walk into when I'm in my high-risk clinic at our safety net hospital. And so one of the things that the medical school has started doing is the week before a first-year medical student starts school, the week before they begin their actual classroom work, the upper level medical students have put together this orientation around social determinants of health, and they've completely written a curriculum on it, and then they just ask for faculty volunteers. So I've been a faculty volunteer to kind of lead through these discussions, but it's this fantastic curriculum that I've actually even borrowed with their permission to give during different talks that I've given, in terms of really helping as the students are entering medical school, understanding these social determinants that, they're not just going to be learning about medical conditions, but, and I think that's one of the other things that, we're trained to diagnose and treat. We didn't have as much training around the compassionate care and the patient-centered care and the, counseling and creating a plan with a patient using their own personal experiences and barriers to help tailor that plan. We were trained to diagnose and treat. And so I think that's where medical schools are looking at their curriculum differently and making sure that their incoming students are equipped to provide culturally sensitive and responsive care and understand that these disparities are due to structural barriers and not because people just don't want to do what you're telling them to do.
Thank you. Ashley, would you like to add anything to that?
Yes, I would add that I think in addition to the traditional sort of didactic instruction, I'm thinking about my training as a psychologist, where there's a lot of focus, on kind of information that really engages your thinking and your brain and your problem solving, that I think curriculum could be, or education could be enhanced by, adding really a component of humanity into our education, where you bring patients and families and have real stories and real experiences being talked about. I think it's some of those things that could really resonate with learners and that go a long way in being etched in their memory, and it could really transform how care is provided as well.
Thank you. And it's really encouraging to sort of hear that these sorts of topics are now actually making their way into medical school, and hopefully we will produce a generation of doctors that are just a little bit more informed, maybe a little bit more compassionate, and generally a bit more aware about their own biases and behavior. I'd like to move now to ask you about your hopes, sort of looking ahead. What are your future hopes, maybe short, medium, long term, in terms of education around disparities?
I think really short, medium, and long term is making sure that as we educate, we really do teach what those underlying root causes are, and work to identify some ways to break down those barriers. And so not just teach about them, as Ashley mentioned earlier, but as we're going through this education, what are things that can be done differently? What are ways to approach this? So, people talk about implicit bias a lot and having unconscious bias. But even my teenage daughter, has now gotten to the point, she's heard me talk about this so much, she can critique unconscious bias training these days. And she said they had a speaker come to their school and talk about it, but she just described what it was. She didn't give us any practical strategies of how you make sure you're not doing it. And so I think it's important to build into the education long-term goals, like short and long-term goals, and also how you plan to achieve those goals. And what are we going to do differently to achieve those goals? Because we can't just keep trying to do the same thing over and over again and hope that it has a different outcome. We need to, and then also learn from things that don't work. Learn from things that work well and build upon those, and recognize when things aren't working, and don't just keep doing them because we think eventually if we just educate a little bit harder around this, or do it a slightly different way, it may work. And but ultimately, long term, my hope is that my daughters, who are now teenagers, when they are in a hospital giving birth, they don't need me there in scrubs to make sure that they have a safe outcome. And ultimately, my hope is that everyone, that it's really moving towards justice, that we eliminate the barriers to having everybody being able to achieve their fullest health potential, and we put things into play that are going to actually improve health for the people who are at the most risk for having poor health outcomes. We need to target where the problems are. It's not a one size fits all. That's where the equity comes into play versus equality. Equality is giving everyone the same thing. Equity is recognizing what each person needs to attain their full health potential. And we need to be individualizing care.
Thank you.
And speaking of those individualized nuances, Christina, we're going to start turning it over now to the audience Q&A. And first question for you: recommendations you have for those patients who can't, quote, hide behind their scrubs. What recommendations do you have for those Black and African-American patients to more strongly advocate for themselves when they feel they are either perceived or actually being confronted with bias and or discrimination?
Yeah, that's a really hard question to answer, because that's like telling Ashley, well, you should have talked louder, or you should have gone more often, or you should have done this. And it almost puts like the ownership on that person. What I have told patients before, though, is that if they have concerns that they feel are not being addressed, to ask to speak to the patient advocacy group at the hospital. So, most hospitals, most organizations, everywhere has a place where a patient can submit a complaint. For lack of a better way to describe it, there's always whatever it's called in your hospital or your organization, there should always be a way to report a concern. And for patients, I've told them that we are now learning that it's discrimination and unconscious bias and racism that are leading to poor outcomes. And if you feel that your concerns are not being addressed, please ask to speak to somebody else, or ask to speak to the patient advocate, because then you run the risk of, somebody's getting louder or trying to be more of an advocate, then they're getting labeled as the angry Black woman, or, the aggressive Black male who's their partner trying to advocate for them. And so it's hard to say this is what patients should do, because they're already doing what they're supposed to be doing. And so the only thing I can add to that is to make sure our patients understand also that it's not just because they have high blood pressure that they're at risk for bad outcomes. It's also because of how their concerns may be addressed. And if they feel that they're not being addressed, ask to speak to someone in a department that represents the patient.
Ashley, given what you went through with your son, anything you'd like to add to that, both personally and professionally?
What Christina just said in terms of, just recognizing that those experiences do happen, and that, you as an individual who knows your body or knows your child, or, you're observing things changing or happening to your family member that concerns you, I think, I think it's important to be able to go to that patient advocacy office and make the complaint. I would, add that. I think it's just, I think that my experience really, led me down a focus on really thinking about what institutions and providers could do differently, really taking it off of the shoulders of the patient, because oftentimes they're doing, just like Christina said, everything that they're supposed to be doing and voicing what their concerns are. There's a desire to partner with the healthcare team to figure out what is going on and what is wrong. So it's just really thinking about what we could start to do differently at the provider level or even at the institutional level.
So, Christina, you already alluded to when you were speaking about some of the things that your institution was doing in terms of educating the trainees regarding health disparities. I wonder if you want to maybe expand on that. Is there anything else that your institution is doing? For example, are there any key measures of disparity that they are focused on to facilitate this education?
Yeah, so within quality and patient safety, there's always a dashboard. There's different measures that we look at that we've always historically looked at. So you may look at things like, what is your C-section surgical site infection rate, or what is your readmission rate, or just different hospital metrics that people look at. And there have been, so the nice thing is there have been some statewide efforts that are, and national efforts that are all aligning around improving outcomes for all and reducing or eliminating disparities. And a lot of them have to do with standardizing medical care. So the more you standardize how you practice clinically, the less room there is for your own interpretation and your own unconscious bias. So if you know that this blood pressure is supposed to equal this medication treatment, then you have to take away the myth of, oh, she's just in pain, that's why her blood pressure is high, and oh, she's just, nervous or something like that. So there are some statewide quality and patient safety bundle implementations at hospitals to reduce the complications around hemorrhage and to reduce complications around high blood pressure, around infection or sepsis. And as we do this, we are looking at our measures stratified by race, ethnicity, and even preferred language, because again, in Houston, we do have a very diverse population. We do have a lot of patients who do not speak English. And so we talk a lot sometimes about health literacy and understanding the information that we're giving around medical conditions, but there's also even literacy language barriers from a standpoint of not communicating in the same language. I've even had patients where when I really kind of sit with them and I'm like, well, they're not taking their medications the way I prescribed it. I had a patient who finally admitted when she picked up her prescription, the instructions were written in English and she only speaks Spanish and she didn't know how to take them. But it took a few minutes of sitting there and really trying to make her feel comfortable and not being like, why aren't you taking your medicines the way I told you to? But, is there a particular reason? Is there something? And then finally, I was like, are your instructions in English or Spanish? So I think there are, and because of that, actually kind of coincidentally, a few weeks later, my hospital announced that when you write prescriptions, when you put in the electronic medical record, a prescription to send to a pharmacy, you have the option of selecting the instructions to be in English, Spanish, or Vietnamese, which are the top 3 languages spoken in Houston. So those are some ways to recognize there's a disparity, understand the root cause, and then put in a solution. That seems really simple, but before that, I had no idea that my patients who don't speak English were getting prescriptions that were written in English. And so I think those are some things that we're learning as we examine adverse outcomes. So one thing is to implement patient safety bundles, standardize care, and look at your outcomes by race, ethnicity, and language. And then as you identify disparities, look at what is causing those disparities or what do you think could be causing them, and work to implement solutions to those specific barriers. And then as you approach every patient safety effort, we approach it with a health equity lens. We go into it knowing there are probably disparities. What are that? Let's find them. Let's not try to hide behind aggregate data and just put up what is the overall for every patient in the hospital, what is their rate of hemorrhage, but what is the rate of hemorrhage in the Black women versus the white women versus the Hispanic women versus the women who don't speak English, and or what is the rate of complications from hemorrhage. And so that's how we've approached it.
Thank you. And it's really encouraging to sort of hear that, these steps are now beginning to be put in place. And I think looking at your own data from your own institution is probably a good driver to really focus attention and to bring minds to be more solutions focused. Ashley, is there anything that your institution is doing around education on this topic?
Well, some of the other pieces, I think trying to get at the social determinants of health or the conditions in which people live, work, and raise their families, is just trying also some novel sort of continuing education efforts. A lot of it, as I mentioned, is often didactic. We, sit and listen to a lecture and sort of we're on the receiving end and we're focused on soaking up a lot of information as an attempt to change our attitudes, our understanding, or our behavior. But we've also tried various strategies, like I mentioned, things like hearing patient stories, as one strategy to see if we could change outcomes, or also just novel things where you're reading, more literature to hear perspectives of diverse writers. So individuals in the Black community who have written books about, health equity issues, and, being able to have a conversation and talk through what the root causes potentially could be, how that may relate to inequities that we see in our setting. But, what Christina said is essential, that it really starts with understanding the data and being able to break that data down by race and ethnicity. And then, you could come up with a strategy and continue to evaluate it over time. Are you really making strides in reducing those disparities? But I think in terms of our group, we've just, really been focused on trying some novel continuing education strategies.
Ashley, you had me thinking with your comment about didactics, lectures, education. Many of our colleagues watching this work with pharmaceutical and biotech clients. They work with designing educational materials that providers share with other providers, or that sales reps or medical science liaisons provide to MDs and PhDs and DOs. Starting with you, what advice do you have for us and those that work in this medical communications industry on how we can collaborate and proactively advance this agenda with our pharmaceutical clients to address disparities and inequities?
I oftentimes think about ways that you can engage, patients actually in taking a look at what those communications are. Does it, are there key pieces of education that are important for a provider to know working with them as a patient, that they would want, to make sure their provider is educated around a particular topic? I think that is one piece that's important. I also hear, I'm not as certain in terms of the communication or the education, to like a pharmaceutical representative that you mentioned, but I do hear on the patient side, when they even receive sort of education materials from their provider or from a device company, for example, that it often, it doesn't even have images that, resonate with them, that represent them as a minoritized person in the US. And so I think also just being able to take a look and make sure that the images and the wording that's provided there could really, resonate with diverse communities and for what we were talking about today, the Black community in particular.
Okay. All right, Christina?
Yeah, no, I don't really have much more to add to that. I think everything that Ashley just mentioned, and as, even maybe including a patient story, like the patient telling their own story of, when my doctor tried to teach me about the importance of prenatal care, this is what I heard, and, or maybe even just really break down, like we're taught all of this medical, it's a whole different language. You go to medical school and you learn an entirely different language of how to talk about and describe disease processes, but then you have to switch back into a different language when you're talking with patients. And it's difficult to go back and forth. And I think it's really important that the way we are teaching people how to communicate this information. We may think it's really important to stop smoking, and we can list all this data about, why you shouldn't smoke, but is that what's really going to resonate with the patient? And so I think it is important to hear from the community what, how they want to receive the information, and to make sure the educational materials do represent the community. We're even thinking about that in hospitals, like the pictures you have hanging on your walls, the magazines you have in your waiting room, however you're advertising something, does it look like the community that you serve? And is it going to, feel welcoming and inclusive to the community that you're taking care of?
I want to touch upon a point you made earlier, but also kind of merge it with this question. We've seen drastic changes and insights brought to life because of the pandemic. We're also seeing changes in things like EMR usage, data capture, and also telemedicine. And starting with Christina, I don't know, could you give some insights on how you might approach or have a discussion differently in the room versus on telecom video conferences? Are there nuances you bring to each conversation, having lost the proverbial bedside touch of medicine in that telemed, and how that relates to health disparities and those kind of talks?
Yeah, absolutely. I mean, I think when you're, so I don't actually do telemedicine video, but I have at our safety net hospital, I will do telemedicine as in telephone calls. And so it's even that much harder where you have no visual connection. And sometimes there's even a different language and you've got an interpreter on the phone with you. And I remember one time, like pretty early in the pandemic, when we were calling a patient who had come in and delivered preterm. Her baby was still in the hospital, and she had been discharged, but she had really elevated blood pressure. She had preeclampsia, and we had sent her home. So one of the things that we thought that was just really fantastic that we were able to do in an effort to keep patients from having to come back to the hospital so much is we were able to discharge our new moms with home blood pressure cuffs so that they could check their blood pressures at home. And instead of having to come back in for this postpartum visit to check on their blood pressure in clinic, we could just call them over the phone, have them read to us what their blood pressure values were, and then we say, okay, that's good, or that's really high, we need you to come back in. So this one particular patient had gone home, was checking her blood pressures at home. She also had COVID. She had been diagnosed with COVID during her hospitalization. Well, we called her with a Spanish interpreter to talk to her about her blood pressures over the phone. And she was giving us some readings that just didn't make sense. Like the numbers that is not what you would get from a home blood pressure or from a blood pressure cuff. And so our first thought was she must not be using her machine correctly, but we can't see her. And so we're trying to kind of play this whole game of charades over the phone of where are you putting the cuff? How are you measuring it? Can you send us a picture? Can you FaceTime? No, her phone didn't have that ability to do any of that. Finally, about 10 minutes in, we learned that she cannot read. And so she doesn't actually know what the numbers are, even though she may be checking her blood pressure. She doesn't actually know what those numbers are. And so then we think, well, we should have you come back into the hospital. Well, she's isolating somewhere by herself because she has COVID and doesn't have anyone who can drive her to the hospital since she's still in her contagious window, and she can't get like an Uber service or something. And so she has no actual way of getting back into the hospital. And so that's when we called our social worker to help us with this. But it did make us realize that we can't just send everyone home with a blood pressure cuff. Before they leave, we need to make sure they know how to use it and they know how to read the numbers. And so those are some of the things that we've learned from the telehealth, telemedicine that has really come out. And then some patients don't have access to internet. So even with these video connections, we don't always have, the patients don't always have access to broadband internet. And so while we thought that telemedicine may be able to reduce disparities and inequities, in some ways it's actually expanding them because these same populations have limited resources for telemedicine.
Ashley, any points you'd like to add, particularly given you're in pediatric mental health?
I think, behavioral health or mental health is also just overall an area where there are disparities when you compare it to sort of physical health services. But I think what we know about mental health is that in the African American community and the Black community, that they're less likely to receive behavioral health and mental health services. I think, part of that is, the awareness or the availability of behavioral health services is a huge challenge. And so I think, what we're starting to see with regard to COVID is that, it's having huge impacts on mental health, across all ages, across all race and ethnic groups. But when we think about, how COVID has disproportionately impacted the Black community, that just makes it, it really even more important to sort of think about how can we make sure that we're expanding care and making sure that mental health or behavioral health services are available in a way that is acceptable and resonates with the Black community, and thinking about, how can we partner, I think, with, as a healthcare institution, how can we partner with other places where the Black community may seek care for their mental health, and partner with them in terms of raising awareness of the services that are available.
Great, thank you. I think we're approaching the end of our time here together. We heard a lot of great valuable insights and practical experiences with health disparities and inequities, both from your standpoints as a healthcare provider, but also, Ashley, in your case as a parent. I think we had some great discussions and solid feedback on medical and health-related information and educational materials that our colleagues can bring forth, particularly with our clients. But also, I think importantly, we heard hopes and goals and aspirations for the future that we all can really internalize and actualize. And with that, I can't thank you enough for all your time and efforts and for everybody joining. And again, I want to give a big shout out to our esteemed guests here, Dr. Ashley Butler and Dr. Christina Davidson. And I hope everybody can take these insights and move forward in a positive way. So with that, I thank everyone for their time.
Thank you.